discussing a case of 50-year-old female who had been complaining of a growing mass in her gluteal region on the right side. She also had a vague complaint of low backache or the symptoms of sciatica, which we say, radiating towards her right lower limb. So in this case, I'll be showing an MRI of the hip joint. So these are the T2 and T1 weighted images respectively taken in the coronal sections, and here we are seeing a large lesion which is staring at us in the right gluteal region extending to the right proximal thigh. So besides this, we'll first study the routine things that we should go through. We'll see the joints, the hip joints, no effusion, no synovitis. Then we'll look at the acetabular labrum. Is there any tear, any paralabral cyst? How's the capsule? Is it thickened? Any synovial effusion beneath it? How does the bones appear? Is there any marrow edema? Is there marrow irregularities? Any T1 hypointense areas? How do the joints appear? The pubic symphysis, the hip joint, and the sacroiliac joint. And besides that, how do the muscles look? Is there any edema, muscle, any collection is there? So this is a stir images. We are seeing that there is no edema, no changes of any soft tissue denervation, or based on this lesion we are not seeing any tendinous pathology as well, no any muscular pathology. So first we'll just take this away so that we can focus now directly onto the lesion. So I'll just get an axial images. This is an axial T2 sections that I will show. So this is a lesion which appears somewhat ovoid in shape. It is craniocaudally elongated lesion, and this lesion is seen in the intermuscular plane. It is seen deep to the gluteus maximus and superficial to the gluteus medius muscles. There is a clear space of fat surrounding the lesion. Now on stir axial sequences, we are not able to see a homogeneous suppression of fat, but still we are seeing that the lesion itself is well demarcated. It appears hyperintense on stir images and bright on T2 with subtle T2 hypointense areas within. And on T1 weighted images, we are seeing that it appears completely dark. No signals whatsoever, abnormal hyperintense signals seen within. Now we'll go to a post contrast image here. In post contrast images, we are seeing that there are certain nodular areas of enhancement which are seen within the lesion. This is how it looks. So these are the imaging characteristic of the lesion. Now we'll study how the lesion is located. So the lesion is located along the expected course of the sciatic nerve. See, from here in the posterior aspect of the pelvis, will start seeing the formation of the sciatic nerve, which goes on and is seen anterior to the piriformis and is seen exiting this pelvis through the sciatic notch. So here this region is the sciatic notch, and the sciatic notch is converted into superior and inferior component by the sacrotuberous ligament, and it becomes a foramen. So the greater sciatic foramen is the region from where the sciatic nerve comes out from the pelvis, and this is from the anterior aspect of the piriformis. Piriformis itself is a component of the greater sciatic notch. So we see that the sciatic nerve is seen here on the right side, and in the same way we are seeing the sciatic nerve on the left side. So if we go on and trace inferiorly, we'll be able to see that this sciatic nerve is seen exiting, and just as it exits, this lesion, soft tissue lesion, is seen somewhere in this region. It gets embedded within the fibers of this lesion, and as we trace inferiorly, we are seeing that some part of the sciatic nerve is intact and normal. Rest all is seem to be within or going through the lesion. We are not able to differentiate it. As we go inferiorly, we are seeing this again the formation of the normal sciatic nerve. So I'll just demonstrate it on the coronal sections. In this section, we are able to see the nerves which are coming and coming out of this lesion. So this is the exit of the nerve, and this is the nerve which are seeing entering within the lesion. So based on this images and the given information, it becomes obvious that this pathology is somewhat well defined. It contains myxoid type of content, no fat content is seen, it is well defined, there is a well rounded margins, demarcated margins, no internal cystic areas are there, there is a split fat appearance. And so this becomes the typical case of a nerve sheath tumor. So the signs that become helpful for showing us a nerve sheath tumor is the target sign, the central hypointense area and the peripheral hyperintense appearance. This peripheral hyperintense appearance is because of the myxoid component of the tumor, and this hypointense area is because of the fibrous nature. Then there is a well demarcated fat plane. So this is the split fat sign, and the sign that we see of the nerve root which is coming out of this lesion is the exiting nerve root side. So in the region, if the lesion is there, some of the differentials that we need to think about, especially if it is in the region closely abutting the sciatic nerve, would be a nerve sheath tumor, whether it's a ganglion cyst, whether it is a lipogenic tumor. For that we need to see, is there any fat component within, but we are not seeing any fat within, so this is negated. Then one another thing that can occur is a vascular tumor. It can be a hemangioma, it can be a slow flow malformation, which this isn't. One another thing that we see, as it is close to the bones, one another thing, periarticular region we should rule out is a sarcoma. So a typical case of a sarcoma, if it becomes so large like the one we see here, it definitely should show some amount of necrosis, some amount of hemorrhage within, and this lesion does not show any of this findings. So this is a typical case of a nerve sheath tumor which is seen in the region of the sciatic nerve as it comes out of the pelvis and is seen in this gluteal region, and it might also be the cause of the low back ache and the cause of the sciatic like symptoms in this patient. Thank you.